Thank you for the invitation. My name is Omar Sued. I am honored to be here today in time of COVID-19. Here are my conflict of interest. As we work toward 1990 goals, the best individual outcomes will come from a shared decision-making process between the providers and the patient. The discussion has to include patient preference, needs, and values, and potential pros and cons of cabotegravir as PrEP. A shared decision will facilitate not only acceptability, but also the persistence in PrEP. One critical issue with any intervention is always tolerability. However, although injection will produce some pain, many individuals would prefer this option over the pills. Actually, in this merged analysis of patient-recorded outcomes of the two large trials using CAB and rilpivirine as a way to simplify HIV therapy, almost all participants prefer the injectable options. CAB-treated patients show with high treatment satisfaction and high acceptance. Of interest, the tolerance to injection also improving during the study. We saw good acceptability also among HIV-negative individuals as reported in this phase 2 trial. Even when injection site reactions were common, most participants were satisfied, were willing to continue, and would recommend this therapy to others. The HPTN 077 is a multicentric study that included sites in the US, South Africa, and South America. Here, the preference and acceptability for CAB were high across all regions and increases over time, but were even higher outside the US. Another key point is that reporting pain was not associated with lower preference for future use. These results were critical for further development of this product as prevention. But who are the best candidates for long-acting PrEP? At first sight, it seems that those individuals with high risk of acquiring HIV, in which we predict will be poor adherent to oral PrEP, will be the best candidates. For example, those with chaotic lifestyle or with unstable housing. But we should be alert about what are the factors that are making these individuals more vulnerable. CAB or any other medication will not be a silver bullet for people with vulnerabilities. For a high efficacy, we need to involve communities in the design of programs, as persistence in treatment will be as important as scaling up, in particular for avoiding the emergence of resistance to cabotegravir. Regarding acceptability, there are many surveys across the world and almost all with positive results. This is an example here among female bar workers in Dar es Salaam. 78% of them were interested and 60% had preferred this option over others. However, only 5% had ever heard about PrEP, so it is important to raise awareness. Transgender women are only one of the most vulnerable populations at HIV risk. Discrimination in the health sector, police violence, drug abuse, depression, and survival search work are important barriers to access to HIV prevention programs. Surveys and qualitative research shows that acceptability for CAB is very high, but it is critical to understand that transgender women will give priority to her gender-affirming therapy over any other treatment, creating opportunity for this integration. Beatriz is showing here in this conference some results regarding the 10% of transgender women included in the HPTN 083 study. And finally, persons who inject drugs have positive views about CAB as PrEP, in particular homeless or those who forget to take their pills, but more efficacy studies are needed in this population. But as always, there are issues that need to be addressed in advance. This includes the economical aspect of the intervention, what it will cost, who will be paying for this in countries without a universal care system. Also logistics, good planning and logistics are needed to ensure that supply and demand are well matched to avoid stock cows and expiries, in particular in walk-in clinic where we cannot estimate the monthly use of this drug, and obviously, we will have to make changes in our service delivery models. Our clinic should be adapted to take on the extra work that will represent one injection every 2 months, in particular if we also are providing injectable HIV treatments. So we should explore other systems such as mobile vans, domiciliary care service, or working with community organizations for providing injection. And we need to implement systems for tracking this injection and reminding patients of missed visit. In this adaptation, it is critical to have the input of the users. Provider buy-in is crucial, and we need to address PrEP knowledge and prejudice to be able to provide a cultural, competent, and sensitive care. This PrEP program should be seen as an opportunity to restructure patient care, sexual care, and prevention. We should understand what the individual's motivations are. Risk perception is one important issue, as patients who perceive them as a low risk might believe this product that remains for months in the body is not necessary for them. The stigma is also important, in particular if the administration is at the HIV clinic. So, effective messaging for key populations are needed, focused on empowerment, intimacy, and sexual health, as well as targeted strategies for other populations such as migrants. But still, we must continue doing research. There are several aspects that need to be better understood to continue informing a good implementation, such as the injection fatigue or the self-administration. Many of these aspects are actually being explored in current trial and will provide incredible input for implementation. BioPIC is a platform that is devising the roadmap for quick implementation. This included a specific proposal for disseminating evidence, for understanding the resources needed, and for scaling up implementation process, uptake, and continued use. These tasks might not be easy, but it is important to continue, as I am sure this new technology will not only represent another pre-option, but will represent an incredible opportunity to avoid thousands of new HIV infections. Finally, I would like to express my sincere thanks to all my colleagues and patients of Fundación Huésped, and a special thanks to my mentors, Pedro, Rafael, and Beatriz, and please stay home. Thank you very much.